So the topic I have been given is practical algorithms in Barrett esophagus. I wanted to give a little bit of a background because I know it's not as common in this part of the world. So we'll talk a little bit about epidemiology of esophageal cancer, pathogenesis, definition and classification, risk factors for Barrett's and esophageal cancer, malignant progression, then the diagnosis of BE and dysplasia, surveillance protocols, and then management of dysplasia and the different options. The picture is of Lord Norman Barrett, who first described this entity. He thought it was a failure of the embryonic lining that caused columnar epithelium, and we know that is not so. So I will be using the acronym BE for Barrett's. I'd like to start with a patient of mine from about 12 years ago. This was an 82-year-old male, white male with severe coronary artery disease and Barrett's esophagus. He was undergoing a surveillance endoscopy, and biopsies revealed intramucosal adenocarcinoma. He had EUS, which in those days we used to do for this, and it showed intact submucosa and no adenopathy. And he had done his homework, and he said, I do not want an esophagectomy. So this is a narrowband image picture. At 6 o'clock here, you see the irregular mucosal pattern, loss of the fine mucosal pattern, and that is suspicious for the cancer. So what did we do? We offered him a band ligation-assisted resection, just quite easy to do in a very small area like this. And 12 years later, he still sends me Christmas cards every year, and he has a beautiful esophagus with no evidence of recurrence. So this is obviously a great story, and it sets the stage for the rest of my talk. So esophageal cancer is rapidly rising, and globally, we have squamous cancer, which is more common, but it's together the 6th leading cause of cancer death. Here, I'll focus on esophageal adenocarcinoma in the context of Barrett esophagus. As you can see in this study, or in this graph, this pink line represents the rapidly rising incidence expressed as a rate ratio, and it's rather dramatic when compared to some of the other cancers listed over this 25-year period. Unfortunately, the mortality curve parallels that, and apparently we've not been able to impact on the mortality. The mortality is stage-specific. So the 5-year survival for early esophageal cancer is 84%, localized cancer is 40%, regional 22%, and metastatic 4%. So by diagnosing this early, we can make an improvement in survival. So very briefly, the pathogenesis, we all have a squamous esophagus, and acid and bile reflux, as we've heard, and other insults can cause chronic inflammation. And if you have the right genetic makeup and certain other factors, the healing happens with intestinal metaplasia and progresses through some DNA content abnormalities into low-grade and high-grade and adenocarcinoma. I want to point out that some studies have estimated the prevalence in certain population as high as 7%. And overall, the prevalence is thought to be 1 to 1.5%. But I was looking up even in the Middle East, certain places like Jordan, and I saw even some studies from Egypt have a higher prevalence rate. You all know that better than me. The annual risk of esophageal adenocarcinoma is 0.1 to 0.2% in patients with Barrett's. What about the risk factors? If you have multiple risk factors, we will consider screening, and I'll go into the guidelines. But the risk factors are age over 50, male sex, white race, chronic GERD, tobacco use, first-degree relative with Barrett's, and high BMI. And a waist-hip ratio and the waist circumference correlates well or increases the risk. This table contrasts the risk between squamous and adenocarcinoma, and as you can see, some risk factors such as Barrett's and weekly reflux symptoms are specific for adenocarcinoma, whereas others, such as the radiation after breast cancer, is a common risk factor. So there are multiple society guidelines. I just wanted to touch on one of them, which is more recent and more detailed, the American College of Gastroenterology. So for men with greater than 5 years of GERD or with weekly symptoms and at least 2 or more risk factors, and again, risk factors are age over 50, central obesity, you have the waist circumference and the waist-hip ratio, being Caucasian, smoking, first-degree relative. If you have at least 2 of them, then it merits screening. Conventional endoscopy is still the gold standard. You have unsedated transnasal endoscopy with excellent sensitivity specificity, but it's not so popular as it's unsedated. And then there's also esophageal capsule and esophageal non-invasive cyto sponge. These are promising, but not yet in mainstream or in the guidelines. So what is the endoscopic definition? So Barrett's esophagus is a change in the distal esophageal epithelium of at least 1 centimeter that can be recognized as columnar type mucosa at endoscopy and is confirmed to have intestinal metaplasia on biopsy. So you need both the visual component and the biopsy component. An extension of the salmon-colored mucosa into the esophagus less than 1 centimeter is classified as specialized intestinal metaplasia. That's what the acronym stands for, of the EG junction and not Barrett's, because this has a very low risk of adenocarcinoma. You all know these landmarks, but it's important to document it in the endoscopy report so your colleagues can know exact measurements if they come across the same patient. The diaphragmatic hiatus, as you know, is where the crura pinch at the GE junction. The proximal extent of the gastric folds is the widely accepted anatomic esophagogastric junction, and the squamocolumnar junction, or the Z-line. So specialized intestinal metaplasia refers to the intestinal type epithelium with goblet cells, as you are probably well aware of, and here you can see the mucin in the goblet cells, in the blue color here. If you have a PAS stain, it's black. And just some examples of the low-grade and high-grade dysplasia with the crowding of the cells in the crypts, nuclear stratification, and there are many changes, and this is more exaggerated in high-grade. You do need 2 expert pathologists to confirm this, but of course we have to be aware of these findings. The Prague classification is the internationally accepted endoscopy classification, one of the few internationally accepted classification that endoscopists use, where you should do this before you do biopsies. You have the anatomic GE junction first located, all measurements from the incisors, and then the circumferential extent of the Barrett's, and then the maximal extent, all from incisors, and then you write it as C for circumferential, in this case 1 centimeter, and M for the maximal extent 4, and this is used in all endoscopy reports with Barrett's. Arbitrarily, the Barrett segment is divided into either long segment, longer than 3, or short segment, less than 3 centimeters, and this is used, multiple research studies. So what is the risk of malignant progression in Barrett's? This is a large population study of 8,500 patients, where the definition they used was a columnar-lined esophagus, which is used in the UK, and the incidence of cancer and high-grade dysplasia combined is 0.2%. About 46% of this cohort had specialized intestinal metaplasia, and in that group, the combined incidence of high-grade and cancer was 0.4%. So depending on the definition you use, you have the incidence of cancer, and the risk of cancer is elevated if you have the SIM in men and in low-grade dysplasia on index biopsy. So cancer risk is clearly dependent on the presence and the degree of dysplasia. If you have no dysplasia, it's 0.2 to 0.5%. If you have low grade, it's 0.7% per year, and high grade, it's 7% per year. And these are the risk factors that you are familiar with. Interesting addition is lack of NSAID, PPI, and statin use is also considered a risk factor for development of cancer. So to delve a little bit deeper into the risk of high-grade dysplasia and adenocarcinoma in patients with intestinal metaplasia or low-grade dysplasia. There's a study with about 147 subjects with low-grade dysplasia. 2 expert pathologists reviewed it, and 85% were downgraded to metaplasia. In the remaining 15% with confirmed low-grade dysplasia, the incidence of high-grade or cancer was 13% per year, as opposed to 0.4% per year in intestinal metaplasia. What about the risk factors that lead to development of adenocarcinoma? Another study of 700 patients followed IM or low-grade dysplasia for 4 years, and these are the risk factors. Presence of low-grade dysplasia, known duration of Barrett's for at least 10 years or more, long length of Barrett's, and presence of esophagitis. This is a subset which is likely to progress. What if your patient has high-grade dysplasia and you want to counsel them about the risk of cancer and then discuss endoscopic or surgical management? There are 3 large studies. The study by Reed followed 76 patients for 5 years, and there's a 59% risk of cancer. And if you look at this study by Schnell, 79 patients for 7 years and 16% risk, so wide variation. And this study by Butar from the Mayo Clinic stratified the high-grade dysplasia into focal and diffuse, and you can see a very dramatic difference in the risk of cancer. This information is very useful when you discuss endoscopic versus surgical options with your patient. Is there a magic number of biopsies that you should perform to increase your diagnostic yield of metaplasia? This study says if you do 8 random biopsies in the Barrett segment, you maximize your yield of detection of intestinal metaplasia. But if you have short segment Barrett's, 4 biopsies per centimeter is recommended, and 1 biopsy per centimeter of tongue of Barrett's. And high-resolution white light endoscopy is a must, as it is superior to standard definition in detection of dysplasia. And it's also interesting to note that the time you spend inspecting the Barrett's correlates with the detection rate of high-grade dysplasia and adenocarcinoma. So spend time, use high-definition white light, and do 8 biopsies. What about narrowband imaging? There is a prospective randomized trial that compared high-definition white light and narrowband. And basically, both are equivalent in detection of metaplasia, but NBI required fewer biopsies per patient and detected a higher proportion of rate of dysplasia, areas with dysplasia. Therefore, it is more efficient and probably cost-effective. And in this picture, you can see the narrowband image and the white light image, and it's very easy to spot this area with loss of the fine mucosal pattern, which is likely intramucosal cancer. So how do we do Barrett's surveillance? Here, I briefly mentioned the Seattle protocol. First, it is important to discuss the risk and benefit of surveillance with your patient. If they have other health conditions that would affect their longevity, then surveillance may not really matter. So if you have intestinal metaplasia, 4-quadrant biopsy at 2-centimeter intervals is recommended. And if you have dysplasia, 4-quadrant biopsy at 1-centimeter interval is recommended. If you get indefinite for dysplasia on the pathology report, this is rather confusing, and what is recommended is optimizing PPI therapy. Many of these patients have active esophagitis that has not been adequately treated. So you optimize the therapy, repeat endoscopy in 3 to 6 months. If the answer remains indefinite for dysplasia, then you put them in an annual surveillance program. If you have any mucosal abnormalities, endoscopic resection is a must, or if it is very subtle, at least a biopsy, and the histology guides further management. If you suspect Barrett's and you do not have biopsy confirmation, a repeat endoscopy in 1 to 2 years should be performed. This Kaplan-Meier survival graph shows that patients enrolled in a surveillance program have much better survival than those who are not. There are many problems with surveillance. Sampling error. In some studies, prevalence of cancer in high grade is up to 40%, making surveillance a very dicey strategy. Poor agreement between pathologists, practice variation is very common, cost is high, and there is patient non-compliance. We still recommend surveillance for metaplasia, but not for dysplasia. So to recap, if you have flat columnar Barrett's mucosa, you do the cold biopsy as we discussed, and if your histology shows non-dysplastic Barrett's, repeat EGD in 3 to 5 years. If it is indefinite for dysplasia, optimize PPI therapy, EGD in 1 year, if it is again indefinite, or manage according to the new histology. For confirmed low grade, confirmed high grade, and confirmed T1A intramucosal cancer, endoscopic eradication therapy is recommended. What about esophagectomy? Is there still a role? Yes, for submucosal invasive cancer, for poor grade 3 differentiation, in patients with lymphovascular or microvascular invasion, if you see these on EMR, or if the lesion is too large or fibrotic and not amenable to endoscopic resection, then esophagectomy should be strongly considered. But keep in mind that mortality is 1 to 2% at high volume centers and 5 to 10 at low volume centers, and morbidity is quite high, and the patient selection here has to be done very carefully. Is there a rationale? What is the rationale for endoscopic therapy? This is kind of the spectrum of Barrett's disease, and between the onset of Barrett's and high-grade dysplasia, as gastroenterologists, we can make a big difference by offering endoscopic treatment and even up to intramucosal cancer. Our goal is to reduce risk of cancer, treat early cancer when the risk of lymphatic spread is low, avoid morbidity of esophagectomy, and last but not the least, EMR provides accurate pathological stage which will guide further management. Is there any role for EUS in patients with high-grade dysplasia or adenocarcinoma? Once upon a time there was, but this retrospective study of 300-something patients with high-grade dysplasia adenocarcinoma, all patients underwent EUS, and this was verified, or the stage was verified by EMR or with biopsy or esophagectomy. And the conclusion was EUS overstaged 7% of patients, and incorrect therapy was recommended by EUS in 11%. So EUS is no longer recommended in this condition. It is out. So to recap, nodular Barrett's, if you find, you directly proceed to endoscopic mucosal resection. And then if your pathology shows low-grade dysplasia or high-grade dysplasia, you proceed with endoscopic ablation. We will talk about that in a minute. If you have T1A intramucosal cancer and favorable histology, which is absence of lymphomicrovascular invasion, nodal metastases, and then you proceed with endoscopic ablative therapy. If you do not have favorable features or you have submucosal invasion, then multidisciplinary tumor board discussion and proceed accordingly. So all nodular disease must be resected by EMR. Though this removes the lesion, I always remind my patient this is primarily for tissue acquisitions so you can get accurate pathological stage and then use that to guide your management. There is a cap-assisted technique and a band ligation-assisted technique. Both are similar in that they have a plastic or a transparent cap at the tip of the endoscope, and you identify and suction the target area into the cap. For the cap, you use saline injection to separate the mucosa from the muscle layer, as there's a danger of trapping the muscle and resecting it. But with the band, it is safer. It is able to only grasp the mucosa, so you do not need any injection, and you can safely resect deeper to the band. Both are equally good, but there's a study which says the band ligation is more cost-effective and also time-efficient. There's a study I want to mention, 170 patients with over 1,000 multi-band mucosectomy, which is the other term for it. Complete resection was achieved over 90%, minor bleeding in 3%, stricture in 6%, and risk factors for stricture are a circumferential defect, which we try to avoid, and a mucosal defect greater than 3 centimeters, which we also try to avoid. Is there any role for ESD for T1A and T1B cancer with patients who are not surgical candidates? First, I want to mention an EMR study, 144 resections in Barrett's intramucosal cancer by Kristen L. And there were no major complications in this study, minor bleeding in 7%, complete resection in 99% with a 3-year survival of 98%. Recurrent cancer, mucosal cancer was noted in 11%, successfully resected endoscopically. So excellent results which make you really question why you need ESD, and EMR is much, much faster. There's another systematic review which compared multiple studies, and basically the outcomes are very, very similar with all these parameters. The only difference is ESD, you have a local recurrence rate which is significantly lower. That is the only plus of ESD. And if you have the expertise with the right patient, you can do ESD. The National Comprehensive Cancer Network guideline is that in the absence of nodal metastases, lymphovascular invasion, or poor differentiation, T1A cancer can be treated with full EMR. For T1B submucosal cancer or T1A with unfavorable characteristic, the choice really depends on the patient's comorbidities and preferences. So moving to the next part is ablation. So there we go. This is a full thickness histology of the esophagus, just to give you an idea of pros and cons of ablation targeted at different levels. If your ablative modality only destroys the epithelium, it turns out you will have buried glands and residual disease. If you do EMR or photodynamic therapy, which targets the submucosa, you can get strictures, perforation, and bleeding. So the ideal depth, the sweet spot, seems to be the muscularis mucosa, which is what we should target. And the reason radiofrequency ablation has become the standard is that the dosimetry was targeted to the depth of the muscularis mucosa. So candidates are flat, high-grade and low-grade dysplasia, nodular, high-grade or intramucosal cancer after you do EMR. This is the balloon-based circumferential electrode. You can see how these are evenly spaced, and this gives a uniform and controlled depth of ablation, minimizes strictures, buried glands, and very little operator variability, so you get a burn immediately like this, and neosquamous epithelium forms in 4 months. This is the randomized controlled trial that was published in the New England Journal of Medicine that made RF ablation the standard of care for dysplastic Barrett's. So 127 subjects with confirmed low-grade or high-grade. One arm had RFA plus PPI. The other arm, sham procedure plus PPI, 12-month follow-up. Primary outcome was complete eradication of intestinal metaplasia. Overall response rate, 77% in RFA, and 2.3% in the sham group. And for low grade, 90%. And for high grade, the response rate was 81%. So ballpark, you can say at least 80% response rate. Disease progression and new cancer incidence was significantly lower in the RFA group compared to the sham group, and stricture was acceptable at 4.5%, not 0, so you have to let the patient know you can get stricture, but this is overall very effective technique and relatively safe and is the standard. What about multimodality endoscopic therapy versus esophagectomy? This is an old study with PDT and EMR. You see complete response 97, 5-year survival is excellent. And another study with EMR, RFA, and esophagectomy, no morbidity with endoscopic, 40% with surgery, similar survival. And low-grade dysplasia, same theme, multi-center European trial, low-grade dysplasia, and the outcome was progression to cancer. You see it reduced by 25% and significant difference in the two arms. Stricture was high for some reason, responded to dilation. So I have one more slide, bear with me. Baseline predictors of poor response. This is helpful when you initially risk stratify your patient. Active reflux esophagitis is a poor indicator of poor response. EMR scar if it regenerates with Barrett's. Esophageal stricture prior to RFA. Many years of neoplasia, this gives you a poor response. And what about recurrence? The risk factors, piecemeal resection, long segment Barrett's, if you do not do ablative therapy, and if you have a very long time to complete response. In summary, surveillance improves your survival, narrowband imaging improves the cost and time effectiveness, EMR alters management and should be performed, mucosectomy is safe and cost effective, RF ablation is safe and effective for flat dysplasia, EMR plus RFA is effective for nodular Barrett's, endoscopic therapy for dysplasia, excellent outcome and is a standard of care, and endoscopic therapy for intramucosal cancer with favorable features is equal to surgical resection. Thank you for patiently listening.